Welcome back, everybody. It's the Pre-Hospital Paradigm Podcast. Why can't I ever get through an opening without you?
Because as soon as I see Ray smiles.
I can't push you guys ever.
Try again. We got this.
One time. We just want... Let me get the whole thing out before you laugh at me rather than... You know what? You're doing the next one, right? I'm Scott Wildenheim. Caleb Ferroni. Ray Pace. And returning, yet again... Dr. Jordan Singer. Hey, thanks for coming back, man. We appreciate you coming back. And it was after his last session, which was all the toxicology, cardiotox stuff.
We all rethought our lives.
He was just like, here's all the stuff. I'm coming back. I'm doing all this. And we're like, all right, we'll scotch you. Come on in. We actually were just going to throw him in here by himself and let him go. But thanks for coming back. We appreciate you. Appreciate you stopping back. And cardiac arrest topics, and then more what I really want to kind of harp on is the post-arrest care, the ROSC care, because there's certainly some stuff that we need to hammer down in cardiac arrest just to make sure that everybody's doing the best practices. But then that post-arrest care, kind of like we were talking off camera a little bit, sometimes it's just like, we got where we needed to be, and we just hurry up and take them to the hospital, and we're missing a huge opportunity there to improve outcomes. So let's talk about just cardiac arrest management things first, and then we'll transition into the aftercare.
Perfect.
Yeah, so what, and if I can just kind of set the stage here, the thing we've been harping on, and I know it's important to you, so I'll just toss the grenade on your side of the table here, is staying and playing and getting these patients stabilized. This is not, and there's still a bad habit of it in a lot of our services, right? Is everything they can do at the hospital, we have capability with a few, a few exceptions, and we probably should talk through those exceptions.
And some people argue that we do it a little better.
We could argue that, right? So the stay and play on the. Why are we doing that? Why is that important?
Yeah, you brought up a perfect point. The first part is that there are two types of patients, right? The stay and play patient, which is most of our sick medical patients, and the load and go, which is more of our trauma patient. But an arrest and a post-arrest patient is the quintessential stay and play, do as much as possible. And you kind of hit the nail on the head, which is the care we're doing in the ER is the same ACLS care that you guys are doing in the hospital, or you guys are doing in the field. And we do know there's tons of data to support that care during extrication and during transport is inferior to the care in the house or in the ER. So we don't want to subject our patients to that less than perfect ACLS care when we can do better care on scene and increase the chance of ROSC. And then once you get ROSC, stabilizing them, and once you do all the things you need to do to decrease the risk of rearrest, get them to the hospital to get the care that they need.
Let's tighten that even tighter. When we say on scene, we're kind of being ambiguous in, the scene itself. Are we talking about the ambulance, or are we talking about where they fell, right? Because I could consider all of those, right? I can consider all of those my scene, right? Is this just about not pulling the truck into drive, or is that? I mean,
I think it just depends on how stable your scing is and what kind of scing you're dealing with.
That's a relatively good point, right? Is let's assume it's
safe.
a safe scene without throwing the variable of somebody's running around with a machete, which you should have entered anyway. But
that was in the last episode.
That was in the last episode, right?
But not to belay your point, but it also depends on. I mean, is this a hoarder house? Is this a house with giant dogs?
Let's just assume that it's a well-kept house.
Yeah, if it's in the living room, then we're going to run it in the living room.
Yeah.
Like, if we have the room, if it's the last one that we actually ran an arrest on and got ROSC back was in this woman's garage.
Yeah.
And that's where she went, and we had tons of room, safe scene. We worked her right there until we got ROSC, and then we took the time and slowly got her to the stretcher and moved to the ambulance.
What do you need better lights for? Does that help with CPR?
Well, you're exactly right. It may be easier, and you may have all your stuff where you need in the ambulance, but that's going to lead to a delay in some of this very important care that is better and more effective if it happens earlier. And so you're exactly right. If it's a dangerous house that you didn't think was dangerous till you got there, maybe the family's starting to get aggressive because they're stressed out that their loved one is in cardiac arrest, you may need to get out of there before you render the rest of the care, and that's fine. Document that in your PCR, and that's totally okay. But if the scene is safe, we want to do it right where we find the patient. I mean, another example is in a nursing home. There's no reason to extricate from a nursing home. Just treat them right where you find them. And a lot of those patients are the ones who are resting on us. And then if you have to extricate partially, you don't have to go, once you start extrication, you don't have to automatically go to the rig.
All the way, right?
Maybe they're in a tight spot and you get them out in the hall and now you have space to work, then work them there. Like you can do a partial extrication, finish the resuscitation, and then extricate fully once it's the time to do that.
So
the bathroom.
I'm going to play advocate here, but why is it so... Why is it so important that we maybe stay in play and not take that time to extricate? And I know I could answer this question myself, but I want to hear it from your side of things, that if I'm taking time to load the patient and I'm putting them on a cot and I'm getting them a squad, what am I losing out there that I could have been doing right there?
So there's two specific things. The first is that during extrication, you're not going to be able to effectively bag a patient if they don't have an airway. I mean, despite your best effort, you're not going to have a good seal and be able to consistently do that. You're not watching the monitor. You're not working on access. You're not doing all those things that are important. And then if you don't have a Lucas, you're probably not doing good chest compressions because it's next to impossible to do it without a mechanical device during extrication. Right. And then the other thing is, you're delaying all those treatments. So you're doing ineffective CPR during extrication, and then all the other important stuff, such as advanced airway, IV or IO medications, you're just not able to do because you're carrying someone out, and you can't do them at the same time.
Missed opportunity to defibrillate a shockable rhythm that in the time you extricate is now, you know.
And the earlier we do those things, the more likely you are to get ROSC. And when you do get ROSC, the less likely they are to have irreversible brain injury, right? We're not in the business of ROSC. We're in the business of neuro-intact recovery. We want people not just to survive. We want them to walk out of the hospital and have a meaningful life. That's the goal.
Sorry, I kind of talked over you there.
You're good. I agree. Like your coronary perfusion pressure's tanking. Like you're not helping the patient at all. You're actually hindering them. But to double back to your point about tight spots, I always think about the bathroom, right? So if you have that arrest, small bathroom, then you have a hallway, you might need to move the patient into the living room 100% just so we have more room to work. And then just a follow-up point on that is document that, because your medical director is going to get a code stat and they're going to see good CPR, and then what's this pause for 45 seconds or a minute that it took you to get them out of the bathroom, drag the patient down the hallway, and then get to another room for work. And it's like, well, what went good after that? What happened here?
Just so everybody's up to snuff on that, is a snapshot your 12-lead monitor takes and reports back every compression, every pause, every analyzation, every shock is all accounted for, every bag. And so you can really put together, any good detective can put together what happened on there, except for the long pauses, and it's why did that take so long? And it'll even warn you that this pause was over 2 minutes, or in some cases, and so it's really an awesome tool that we have to come back at a tabletop after the arrest and say, okay, I got the code stat, let's talk through it. But again, it doesn't tell you what happened, so you need to put in your narrative what happened, because I'm sure the docs are looking at that.
Exactly right.
Yeah.
We don't expect it to be perfect every cardiac arrest, but we want to review these things so we can find little ways that we can do better. We always want to be doing better on the next effort.
Yeah, and it's almost a competition between the shifts now at the firehouse. Who can have a better code stat? And it's gotten us better.
That's awesome.
Yeah, no, that's awesome.
It's friendly like a report card. Yeah, it's like a report card for how you ran your cardiac arrest, and obviously you need a good follow-up run report with that, so we don't just look at one side of it. And I'm sure that's when you review them, you read the run report and look at the code stat. It's not just like a one-sided story. But yeah, it's good competition to obviously get our people to perform at a higher level. That's what we want, and that's how more people survive.
That mindset of I move them to the ambulance because that's where my that's my environment. That's where my tools are at. Well, if that is the case, then you set your tools up wrong, right? I mean, we are supposed to be mobile and portable medicine, right? So that tells me one of two things: either that means people aren't bringing the gear in. And we've all had
or the right gear, or you
just don't have it set up effectively. You've got things on your truck that are paramount to resuscitation that you don't have in your first in kit.
Scott, you have a good point there, and I know this is changing our organization, and maybe it's a moot point, but the way your bags are designed is important, right? You know, the old days when
that needs to be thought through.
I remember when I first started, I mean, the damn jump bag weighed like 85 pounds because it was like, well, we need 4 ice packs in there because I need to take that into their home. And it's like, no, we don't. Like, how can we lighten this thing up? And like, to both of your points, you know, I need some IV access. I need some bags of fluid. My IO is in there as my backup, BVM, end title, other things. You know, so when you're going in to run that arrest, like in our organization, it's 2 bags of monitor and a drug box.
Yeah.
And the 1 bag is the oxygen tank. Like, so, you know, set your bags up appropriately. They also don't need to weigh 85 pounds. They're a lot lighter now with how far bags have come over the years, but everything is labeled correctly and just in its own little spot. So yeah, maybe some organizations need to look and see how their equipment.
That's a fantastic point.
Is
and
designed.
at work,
No, I think it's great.
I designed, you know, StatPat makes a great bag, and now we have an ALS bag and a BLS bag, and together those two will run an arrest. Just bring the monitor and the Lucas.
I think there's, at least historically, there has been, I think, a lot of the agencies I've observed as of late of, you know, that there's been a shift in that mindset is the bag has to be a duplication of my ambulance, and that's not the case, right?
Yeah.
The bag needs to be critical intervention stuff, right?
That can't wait till after
that can't
extrication.
wait till
Yes.
I get him to the ambulance, right? You made the perfect example. Is I've always got crews shoving cold packs in there.
Yeah.
I'm like, look, if they need a cold pack, they can wait till they get to the ambulance.
Well, they're
gonna live long enough to need a cold pack.
Okay.
Well, if
you are
put-
okay, right?
If you put too much stuff in it and it weighs too much, there's incentive then to not bring
Not
the pack
use
in.
it.
So
Yep.
if you
Correct.
make it so it's comfortable and only the critical things are there, people will do best practice. It's,
Yep, it's going to go in the house more.
Yeah.
Especially when you, let's say you get dispatched to that chest pain call, and to your point, well, it's a chest pain call. I'm just going to take the monitor, right?
Yeah.
And that, you know, we all know that. We all know those.
walk out, right?
I'm going to just take the monitor. I'll do my 12 lead, and then you get in. Oh, they're in cardiac arrest now. Oh, now I need that
because they're
bag.
in VFib.
Correct.
First time you turned into a
it's
VFib
like,
arrest.
you know,
Cordial
so
thumb.
it's those little things, and I agree with you 100%. You got to set your tools up to perform. Don't take your whole entire ambulance in the house.
So let me ask you this. I mean, everybody's going to have their own opinions. I bet you we're pretty much mirrored on this one, though. What is your critical equipment?
Suction. All right, I'll
That's a commonly forgotten thing that is
right.
absolutely
This is my
quintessential
pet.
when
That
you
is
need
my
it.
pet peeve.
Sounds like you ran into something once and you didn't have suction.
I have had so many crews. Did I get burned early in my career? Yes, of course I did. I'm not going to sit here and tell you I didn't, right? Yeah, I got burned. But then, you know, you learn from that mistake, right? And then I see my crews doing it, right? And that's part of that setup, right? Is
Yes.
I made sure they had that tool in there, and you know, in my former house now, I mean, that was a yearly thing. We reviewed the kit every single year. It's like,
Yeah.
what do we need? What don't we
What
need?
don't we
What
need?
are we using? What aren't we
Yeah.
using? How's the mission changed? It has the mission changed.
So you got suction.
I absolutely. That's
What else?
Because that is so often forgotten. That's why it's my trigger, right? Airway kit. I'm just going to be broad brushstroke with
Yeah,
that.
we know an airway kit.
Airway kit, and you know, whatever your choice of backup airway is. Of course, BVM, oxygen delivery stuff. Vascular access, and that would be primary and secondary, right? So IV, IO stuff, yeah. And this is, if I can, this is a little pet peeve of mine. Everybody wants to haul those. They keep their IO in that big ass box.
Yeah.
And again, it's more incentive not to take it with you. Turns out that clip in there, that will come out and it'll fit on the gun, and it just
Protects the
Put
trigger.
it anywhere.
like
Yep.
in our pouch we had this was the bag IV solution. Catheters and stuff were here, and then there was a small little pouch that just had the IO stuff in it. You don't need to. Just because it came in that kit doesn't mean you have to transport it in that kit. Again,
That makes a good lunchbox.
right? Exactly. I mean, how many did we take to Bomb Squad for them to make devices in? That's perfect use of it, right? Make them go away.
Glucometer,
Absolutely. Yeah, absolutely.
pen light, stethoscope,
Yep.
manual BP cuff. Yes, I said manual.
Yes.
Not negotiable.
I agree 100%.
Yeah, I don't think that's.
I think auto cuff is no. You
And
need to
then-
take a manual blood pressure, and if you're
I'm
given
okay
medications,
with auto cuff
you need to take
after
a
a
manual blood
manual.
pressure. Yeah. Okay,
And then-
I agree. Yes.
Then see where you're at.
So your gauze products, your tourniquets, and your chest decompression needle, whatever that looks like, and then some sort of surgical airway device, right? Whether that's a quick trach, whether that's a scalpel, whether that's whatever you're using, right?
So I think we're pretty much all on the same page there. And then everything else is kind of fluff. Everything else I like to say is your sign-off bag, and we don't need it. If it's a sign-off, we can go back to the ambulance and grab it and
Grab
bring
it,
it back.
yeah.
I mean, if you think to yourself, if I don't have this piece of equipment for a specific situation, the patient could decompensate and arrest, then you need that
Then
in
you
your
need that.
in your
Yeah,
additional
yeah,
stuff.
Yeah, absolutely.
But
Absolutely.
to your point, originally, I have been on squads, I have been around squads, I've been a part of squads in the past from not learning that the bag is at 80 pounds and everything in the back of the squad is in the bag.
Yeah.
And I don't think we need that.
No, and I think that's a culture thing too. I mean, it changed, it shifted in our place too. Like, I remember it went from when you pick up like this and had the big shoulder strap and you're like walking like this because it weighs so much to ask the crews, what do they want to use? You know, there's so many backpack styles
Backpack,
now.
yeah.
We run stat packs now, so it's a lot easier to me to throw on the backpack. I could grab the monitor, I could grab the oxygen bag, the other guy grabs the the Lucas and the drug box, and we're in the house, and then I don't need to run back for anything.
Sure.
I mean, or the suction goes with us too, but I don't need to make that trip back to the ambulance. I brought everything that we needed inside. It's a safer way. It reduces back injuries. I mean, there's a lot of other reasons why. Stat Pack makes a great kit where you can pare down some of the OEM products casing, if you will, to try to be in more of a user-friendly thing for your organization.
And if you recall, I don't know if it aired yet or not, but we spoke to a doc who was doing heads-up CPR and is very much involved with his departments and set the bags up as a approach style where their engine was bringing in the equipment that needed after initial patient contact with the first bag, and it's working great for them.
And they mirrored that with procedure.
Correct.
Right?
Yeah.
It's like, first in, you're taking these things,
And I thought that
everybody
was
else
spot on,
brings
and I
in
bet you that
bop.
eventually more departments protocol change to tailor that.
Yeah, no, I hope, well, at least based on this and that people are taking that into consideration as part of success for what we've somehow got way off topic on. But
We're still talking about ROSC.
it is
We're
setting
getting there.
ourselves up for success in ROSC, absolutely. Or
I think all this comes back to, though, is what we initially got to the point on, is that being in a controlled environment doesn't necessarily mean you can't be at the patient where they collapse. And doing initial good care there is really what needs to happen.
optimize it there.
In EMS, we bring the care to the patient, not the patient to the
Correct.
care. So we're going to go to them with everything we need.
Right.
And don't get me wrong, I've told my guys this for years, that my comfortable spot is my office, is the back of my squad. It's controlled, it's mine, it's well lit,
I'm
I know
comfortable
where
there,
everything
yes.
is. But again, we bring care to them, and the best care in that position is probably at the patient's side where it happened.
Yep. Their outcome trumps my comfort.
And then maybe as a protocol question, I'll ask you this, because I've been asked this a few times. If I put that patient in my squad and I do my rounds of ACLS and then call it, do I have to transport now because I put them in the back of the squad? And then you get in another predicament.
Yeah, once you're in the back of the rig or like almost fully extricated,
back.
yeah, that patient's going to the hospital. I mean, you can pronounce them there, and then you could transport them to the hospital. They'll go to the morgue, but you don't take them back outside and put them down on the ground. Do not do that.
I think there's two things to tease out there. Is once you started the process, you own them, right?
You own 'em. It's- yeah.
We're moving
But
them.
to your point, secondarily, you can go out there, get on the phone, do a field termination. That doesn't mean you have to continue resuscitation all the way to the hospital.
Correct.
And I've run into that situation before. We're like, well, we put him in the ambulance. Okay.
It's yours now.
Yeah, it's yours. You own them. But then they called medical control, and they're like, we're still just going to work the arrest all the way to the hospital. Rather than they met criteria to field terminate, they should have field terminated, but they felt like they were obligated to continue all the way for pronunciation
I don't want to
at your hospital.
speak for you, but doesn't that timer reset then for you if you get to the patient? If we work them all the way.
No, so I mean, I'm going to say the time of they've been worked for 20 plus minutes, and I mean, if a patient's been worked for 20, 30, 40 minutes, and then they get to me,
They've
I'm
been
probably
worked
going to
for 20,
pronounce
30, 40
because this person's been down for so long. Meaningful
As long
recovery
as
is
we've
unlikely.
crossed as a squad all of our H's and T's, and we've done the rounds of meds if needed. I mean, why wouldn't you? So
I mean,
it's kind of just a waste of resources at that point.
In the state of Ohio, EMS personnel cannot pronounce, so you have to call for pronouncement. And so that'll just be a discussion with the online med control physician of, hey, can we pronounce now? This is the story, or should we continue to work and bring them to you? And that'll be decided in real time.
And this is way off. I'm sorry, but I think this is a good question to ask. What information do you want from squad crews when they call you about a pronouncement? Because I've heard everything from, oh, the address is this and this and this, the current weight is this, here's a list of every med, and it's like, what do you want? So what should I call you with? I mean, a 12 lead, how long it's gone, what medications I've given.
So I think the question you're asking is more in general, how do you do a good report to the ER for a critical patient?
Correct.
So the first thing you want to do is tell the ER physician what your question is. Frame everything. So tell me, hey, we have a patient in arrest that we think is a candidate for field termination. So now I know what I'm listening for to make sure I get the criteria, and then say, patient was found down unwitnessed, initial rhythm asystole. We've intubated, end tidal is X. We've given this many rounds of epi. We can't think of any reversible cause. We don't think that meaningful recovery is likely. What are your thoughts on field termination? If you give me that story, I'm going to be like, I think you're exactly right. Time of death right now. And just give you the go-ahead for that.
I think that's huge, too, because I think a lot of providers want to be like, well, the
They
weather,
want
the
him to be the
temperature
one to tell
outside
them.
is 66 degrees, and it's like, no. And, like, I think that's something we have to teach in our organizations and in our CE. Like, and I'll flip that to a DOA, you know, and we had a new guy on our organization. He's like, well, I've never called med control before. I said, all right, your first sentence is the most important. I need to speak to the physician for a time of death for a DOA. That's all you say.
Frame everything with the first thing you say.
Doctor, this person is an 89-year-old female that hasn't been seen for 3 days, asystole in 3 leads. I have no heart sounds. We have like lividity, da-da-da-da-da. Cool. Time of death is this. What's your last name? Boom. Doc, conversation's over.
Like, you need one better on that.
Like, it's just I think that's huge because sometimes they just start talking and you're like, what the hell are you asking me for?
So it can even be shorter than that for a DOA. You can just give me the DOA criteria. Say, I have a patient that I think is a DOA. They're in rigor mortis. I don't need anything else.
What else do I need to tell you?
I mean, it's irrelevant at that point. So if you tell me lividity everywhere, decapitated, incinerated, you say what the DOA criteria is, I don't need anything else. It's good enough for me, time of death.
Ours is more of mine's a coroner thing. That's why I know, like, they have their little things, so I just say them. But yeah, it can be very pointed, I think. But some people, to your point, want to give this long.
Yeah.
And if you don't sound confident either, that's not really reassuring on your end.
Correct. He's going to want you to work at that.
Yeah, if they're
Let
like,
me figure this
well, I
out.
don't know what to do, but I called you, and it's like, okay, this isn't good. Like in your world,
I think the
was
consensus is, though, because we've talked to, I mean, Dr. Hill obviously had the same answer you did. Dr. Spanner was, tell us what you want, and then tell me what's going on. Like,
You want to frame what I'm listening for so that I don't get to the end and like, oh, I was listening for this, but it's that you need.
Yeah, tell me again these things. No.
Yeah.
And by the way, that was mine. Now my patient's problem.
Yeah. But you talked about missing the opportunity to give some time-sensitive interventions, through defibrillation. Medication standpoint.
So what do you mean?
What medications, we get on scene, we don't want to wait, extricate them out to our truck, we don't want to wait and transport them. What's the missed opportunity if we do that, if we don't start beds, where the patient fell, if you will?
So,
with our meds.
I mean, we know that epinephrine is critical in cardiac arrest, and the earlier we give it, the more likely we are to get the heart to start beating. And so we just don't want to delay epinephrine for 5, 10, 15 minutes to extricate it, because sometimes these extrications are quite difficult. What if they're up a spiral staircase on the 3rd floor? I mean, they might just be quick, but we never really know.
Sure.
And also, giving it's not going to help if you're not doing compressions. You need to circulate it.
Well, too, if you think about it, just jump back to like AHA's ACLS algorithm, to your point even more. If I get there and that's an asystole or a PEA patient that I've not established that IV on and not given that epinephrine immediately to, I mean, you're not helping your patient at all. Or on the flip side, if it's a shockable rhythm, VFib or pulseless V-tach, and you haven't put them on the monitor, delivered good CPR, and also tried to do 2 defibrillations before the IV, because I need 2 defibrillations before my epi anyways. So you're just not doing your patient any justice, and you're just killing their brain in the middle of that all. It's just their survivability to walk out of the hospital with, any type of
neurologically
intact is just you're tanking it. So
I mean, you're right. There's a priority that we do things. It depends. If you arrive with just you and maybe one other partner, you have to know the exact order to do things because they can't all be done simultaneously. If you show up with 3, 4, 5 medics, you could probably do everything simultaneously, which is great.
Yeah.
But you should always be thinking, what is the first thing I want to do? What is the next thing I want to do? So if you are by yourself, you know what to do. And so the order is compressions, check a rhythm for electricity if it's needed, and then IVIO access for medications, and then last airway. I see a lot of crews leading with airway, and I would say the only time you should do that is if it's a true airway obstruction. They died because they choked or their airway is obstructed. If that's the case, then sure, prioritize airway. That killed that patient.
Yep.
But for from the vast majority of cardiac arrest, I would rather you start compression, shock, and get IVIO for medication administration before you ever do an airway. I mean, you could just put a non-rebreather on them and not even bag them for a little bit because if they just died, their SAT is 100% right before they died, so it's going to take a little bit of time for that SAT to go down. So you are circulating oxygenated blood in that period.
Yep.
yeah,
And likewise, if you use that strategy and just threw the non-rebreather on them, oxygenation is passive. I mean, everybody thinks
You'll get a little bit of it.
Yeah, is it going to be optimal? No, but everybody thinks that this oxygenates people. No, it's presenting the higher concentration of oxygen is what's doing the trick, not.
Obviously, I would want you to bag that patient, but if there's only 4 hands for 2 people and there's other stuff that needs to be done, there is priorities. And in a perfect world, you have 100 people working that arrest, but that's just not the reality.
100.
No, I agree 100%.
That's true. that may be too many. You're correct.
That boils down to training too and how you practice.
Yeah, absolutely.
It's just
and regularity. I mean, obviously, if you run with the same shift every shift, it gets smoother and smoother.